Top Med Talk.
Well, hello and welcome back to Top Med Talk. We're here at Anesthesiology 2023, the annual meeting of the American Society of Anesthesiologists. Top Med Talk here is in the exhibit hall at the Moscone Center in San Francisco. I'm Desiree Chappell, your host. I'm joined by my co-host, Professor Mike Grocott. Hello, Mike. How are you?
I'm very good, having an excellent day of enriching conversations.
It really has been. Yes, we keep saying the word enlightened. I think we've had some very enlightening conversations, AI, technology, and then how that's affecting the future of anesthesiology. So if you've missed any of those conversations, you can find us at topmedtalk.com on our website. All of the information's there. These videos are going to be going out on YouTube. So please do check that out. Now, Top Med Talk is a perioperative medicine podcast if you've never heard of us before. We're global. We're listened to in over 100 countries. We have over 2,000 podcasts that we've done in the last 7 years, which I know we shake our heads. I can't believe we've done that many, with over 2 million downloads. So lots of listeners, and thank you for listening. We also want to give a shout out and a huge thank you to the American Society of Anesthesiologists. They have helped us. They've given us this beautiful booth here at the meeting. They've supported us over the years. We couldn't do it without you. We couldn't do it without our other sponsors, GE Healthcare, Edwards Life Sciences, and Medtronic. You keep Top Med Talk going, free, open to the world. Right, Mike?
Absolutely. It's a resource which I think a lot of people treasure, which is not just us patting ourselves on the back. It's having that completely open. Because of that support, we can offer it open around the whole world.
Yeah. So at Top Med Talk, we have conversations with key opinions from around the world and leaders in the field of anesthesiology. And today's discussion is no different. We have the opportunity today to talk specifically about payment models and all of those things affecting the world of anesthesiology today. And our distinguished guest, we have Dr. Lois Connolly, who's the ASA Vice President for Professional Affairs. Lois, thank you so much for joining us.
Thank you, Desiree and Mike.
Yeah. Lois, for our listeners, can you tell us a little bit more about yourself?
Yes, I'm a professor at the Medical College of Wisconsin, adult neuro anesthesia, liver transplant in my past, and a big residency program, as well as an anesthesiologist assistant student program. I've been involved in the ASA for many years.
A while.
Yeah. You learn so much. You help people. You explain what you do. I think you make a difference. Yeah. In not only student resident life, but also your fellow anesthesiologists.
Yeah, so absolutely. Well, congratulations. It sounds like you wear many hats and very busy for sure. We have Dr. Jonathan Gao, who is chair of ASA's Committee on Economics. Jonathan, you're returning to Top Med Talk.
It's not my first rodeo. It's true.
I wasn't going to say that, but we'll go with that one. Thank you so much for coming back and chatting with us. Tell us a little bit more about yourself.
So I'm now also a professor of anesthesiology.
Yay, congratulations.
Thank you. As of October 1st, it's official. From the Ichan School of Medicine at Mount Sinai. That's where I practice and have a couple different titles there. One of them is Assistant Medical Director for Offsite Ambulatory Surgery Center Anesthesia. I also am Director of our Governmental and Reimbursement Affairs there. And that kind of relates to my involvement with not only the ASA as Chair of the Committee on Economics, but also with the NYSSA, the New York State Society of Anesthesiologists, as our Chair of Governmental and Legal Affairs Committee for them.
Diving right in, I thought it would be really important. We have global listeners, people listening from all over the world, here in the US, the UK, and Australia. So different payment systems, different models of care. I thought we'd just lay some groundwork now and talk about what it looks like for anesthesiology in the US when it comes to payment models and systems within the healthcare system.
Yeah, basically, unlike some other countries, we have a big commercial payer, as well as Medicare, which is a government program.
National healthcare system.
Our national healthcare system. And Medicaid, which is a state-run payment system as well. We also have some citizens that are self-pay or not insured. That portion is getting less and less over time. But I think as our conversation goes today, we'll be talking about our Medicare, our governmental payment issues that are ongoing.
Yeah.
For example, where I practice at the Medical College of Wisconsin, and this varies throughout the U.S., we have about 55% of our payer mix come from government contracts. Now, that varies in other states where it could be as high as 90 or 95%. So it really has a big impact regionally, depending on where you practice, on what's going on with Medicare payments.
Yeah, what type of facility you come from. There's a lot of different variations on that. I think we've had discussions about this in the past, about the way that physician anesthesiologists are reimbursed in groups and the different practices are reimbursed. Jonathan, can you take us through a little bit about how that works? I know it's, again, variation, a lot's variable through different systems and types of practices.
Sure, yeah. So for the way that we process billing claims for anesthesia services here in the U.S. is patient comes for surgery, we provide the anesthesia services for that. That includes a pre-op assessment, intraoperative care, and post-op assessment as well. Those kind of cover the base units for the procedural code that you're going to want to submitting for that. We use a CPT code, current procedural terminology code. And so there's a anesthesia code that gets crosswalked from every type of surgery that there are out there. And there's about 400 or so of those. So suppose it would be, let's say, a spine surgery, one of the ones that I typically do. Anesthesia for that certain type of spine surgery equals that many base units, and then we add on time units for one time unit for every 15 units of care that are provided. So if it was, say, a 4-hour case, there would be 16 extra time units associated with that. You add those onto the base units. That total gets multiplied by a conversion factor. The conversion factor is basically that rate, the dollar amount you wind up getting paid, and it varies per payer. So it's different for Medicaid versus Medicare versus commercial payers.
All right. So that lays the foundation of where the conversation I think we want to take this is that it is variable depending on who is paying you. But a lot of the times those rates are set by Medicare. Medicare has their own rates that they set. And every year, as we know, there's more and more pressure on the U.S. healthcare system to reduce cost and reduce payment. How is that affecting team anesthesia and anesthesiologists?
Oh, it's horrible.
Yeah. Not to be too grim, but
as it goes right now, it's not sustainable. There was a modeling done by one of the, there's a 33% committee, a subcommittee under the Committee on Economics that did a modeling based on 100% Medicare payment. And basically, it's not sustainable. You cannot sustain a practice based on Medicare payments. A little history behind this. It started in about 1992, the new way we get paid by Medicare. The RBRVS system, as well as the anesthesia conversion factor, they're two different models for physician payments, and they're a little different. We've had some wins with payment adjustments and with CMS over time, and I think the last one was 2005, where we got a 23% increase. But ever since 2005, the payments for our conversion factor has decreased significantly. So now we call it the 33% problem, where we're getting about 33% of what our commercial payers would give us. But in reality, if you adjust that based on inflation over time, it's more like 19%. It's really low. So it's significantly affecting our ability to sustain anesthesia practices without stipends in some areas of the country.
Yeah.
So a conversion factor this year in July is going to be reduced by 3.26%. So every anesthesia unit is relatively about $20.43, which means you might, for a 4-unit case, bring home $80.
Wow. That's very interesting. And so, this sounds like it is a major issue. And I know that there's some advocacy from the ASA happening. So, Jonathan, can you tell us a little bit more about what the ASA is doing to address this? I know we heard from Dr. Chappell last year. Various leaders within the organization talk about this, but specifically, what should members kind of look out for?
For the cuts that are being proposed right now by CMS for this year's Medicare physician fee schedule, the 3.26% cut would be for the anesthesia conversion factor, and then a 3.36% cut for the RBRVS conversion factor, which is the conversion factor for all other CPT codes. And for anesthesiologists specifically, that's the one we wind up using for if you place an arterial line, a nerve block, a central line, et cetera. And then the anesthesia conversion factors for the anesthesia services for those sorts of procedures.
Gotcha.
So those cuts are right now factored in because of a add-on code that CMS is trying to implement. It's this one called G2211. And this is an add-on code that they actually tried to implement back in like 2018 or 2019. And it's been kind of kicked down the road each year because of the pay for that it would have to accomplish. Since there's these budget neutrality laws when it comes to Medicare Part B, which is the physician fee schedule part of Medicare. the budget associated with CPT changes can't go up or down more than $20 million in a year. Now, that's a really small number in 2023 dollars, and that's because it relates to the omnibus bill from 1989.
Oh my gosh.
Yeah.
It has not been updated.
A little bit
It has not been
antiquated
updated.
here,
And so
isn't it?
here we are using, 89-year-old rules.
Oh my gosh.
And so as a result, they can, in order to make adjustments to CPT codes and have an add-on code like this, you have to basically take from Peter to pay Paul. And so 90% of that 3.25% cut is because if they want to implement this G2211 add-on code, which is supposed to represent complexity during a evaluation and management visit, which is very common. Outpatient visits for primary care providers, even some of our pain medicine physicians inside of our own society, they also submit some of these same E&M type codes that have higher complexity, and they would want to add on this code there. But as a result, they're taking away from those other specialties that don't submit those same types of codes. And that's 90% of that drop is related to that add-on code. So we're advocating to kick that down the road again. It's not necessary. It is duplicative of some of the other E&M updates that happened over the last couple of years to try and add some more relative value units to some of those same E&M codes that this would be added on to. And we've partnered with some other specialty societies in as well to try and do this, to try and advocate on behalf. AMA is one of them, but they kind of...
The American Medical Association,
The American Medical Association. The issue there is that some of their members would benefit from this add-on code and some of them would not. Now, we also have what's called the Surgical Care Coalition, which is the American College of Surgeons, 20 plus more subspecialty surgical societies, ophthalmology, otolaryngology, et cetera, orthopedics, and then ourselves as well. That we have teamed up to Surgical Care Coalition, and we're now advocating together to help fight these sorts of the codes and the other cuts. And we've come up with some other legislation as well, partnering now with Congress to try and come at it from other angles then as well.
Wow, that's really important.
Yeah, so a bill is introduced called HR 2474, I believe.
That's what we got,
Yeah, it was presented by the Doctor Caucus in Congress, and they're looking to tie Medicare fee schedule updates to Medicare Economic Index to assure that we don't continually get cuts, but hopefully it will match inflation or economic indexes. There's also some other nuances in that bill that would help. For example, budget neutrality. You heard Jonathan talk about the low budget neutrality that we're working in. $20 million in today's is so low, right?
Yeah.
So they're also proposing that the budget neutrality ceiling be raised to, I think 53 million was the last number that I heard. By the way, whenever they first set the budget neutrality level, it was just a number that they pulled out of a hat. So 53 million really is based on time, inflation over time.
Yeah.
So to kind of correct for that.
It's a very complex conversation. And I think for the average clinician working every day, where can they find more information if they really want to learn more about this? Because I think this is something that it affects everyone. You don't realize it when you're sitting in the OR, churning and burning cases, to be honest. But, this is something that I think is important for everyone to understand.
So the ASA does have a lot of resources online that you can access, even under the committee structure. If you go to asahq.org and look under committees, you will find committee resources under there. Okay. And you can find a lot under the Committee on Economics, who is really at the very forefront of all these economic challenges.
So we realized, we've known this for a while, but we really started to make a big push towards not only fighting those different things in policy and, with Congress and helping provide advocacy stuff for our massive advocacy team that needs to be battling this, but we want to start providing more resources to our members too, to kind of educate them. So there's a whole section in the Payment Progress Initiative called Timely Topics.
Okay.
There's a lot of different information there that's related to all different types of payers and other issues that might be happening. Things, we were talking about Medicare mostly. There's Medicaid stuff now coming out for Medicaid expansion and the rollback of, now that the pandemic is over, how they're, pulling away some benefits there too. We have plenty of stuff on commercial payers, things like the No Surprises Act, et cetera.
Yep.
And then there's also this, probably the best, most up-to-date and current area would be under the FDA and Washington alerts part. So inside of the ASA website, asahq.org, there's the FDA Washington alerts, which can give you the information on, ASA just submitted a comment letter about the Medicare physician fee schedule. ASA just submitted a comment letter about the G2211 thing. All those sorts of things are right there. And that's kind of the most timely and current up-to-date stuff.
Yeah, that's fantastic.
In addition, every monitor article or every monitor issue usually has something about payment updates. We try to educate our members continuously on all the payment issues, because these payments affect all of us.
Absolutely.
Every practice, not one individual practice, but everyone. The ASA also runs a commercial survey on conversion factors as well, and that will be released, I think, actually on Monday.
Yeah.
And
we tried to get it out right before. Friday was too tough for the PDFs.
yeah, it's one way that we can kind of do a survey of all practices to see what commercial contracts are paying for an anesthesia conversion factor. Obviously, it's kind of proprietary. We can't outright disclose that. So the more practices that participate in our annual commercial conversion factor survey, you get a very broad view of what an average conversion factor would be from a commercial payer. So last year, I think it was like $85 was the average. I don't have it right at the very top of my mind, but it was like about $85. And I think this year when they ran the survey, just to give you a little
teaser,
it's 1 cent off. I think it's $85.40 instead of 41 cents. So that's really good news that, our commercial payers are maintaining their contracts as well. I would encourage you to look for that commercial survey coming out.
And I'm sure we have lots of younger listeners or those who are just entering the profession or maybe in residency. Yeah. Are there any other resources that they would use, do you think, that they can learn more about this?
So every residency has a rotation in practice management. And the Committee on Practice Management is building practice management resources along with the Committee on Economics to educate residents on this. Yeah. I'm in education is Jonathan, and we try to educate our residents on this and provide some resources within. We have an anesthesia toolbox that they have access to, that they can get a lot of resources to learn these issues. But a lot of it is just simply showing them what you would do with a bill, right? Yeah. Mm-hmm. So Jonathan walks them through a bill, for example, with this kind of payer, or even with our quality payment program, trying to make up the difference in the low Medicare payment rates that we got, which is very enlightening.
I'm so glad you remember that. So I do a grand rounds talk, and I've gone around, and I've also done it some of the anesthesiology conferences too, and I essentially take a basic case. I do a run-of-the-mill open hysterectomy, and the base units for that, the time units for it, suppose you did a nerve block, stuff like that, and this is how many units that would be worth. And this is how much Medicaid would pay you, Medicare, or a commercial payer. Yeah. And then I start to incorporate other things of, suppose you participated in MIPS, the Merit-Based Incentive Payment System, and you did it really well. You got a perfect score on MIPS, and you got this much bonus. Suppose it was 1.85% or something like that. Now, it's pennies on the dollar, right? But now, you did all that, and you have this extremely, well-qualified practice. Now, that same case for Medicare, you get paid a little bit more, 101.84% or something like that. And then I also bring in alternative payment models, suppose bundles, something like that, with a commercial payer. Suppose you had a bundle set up for the open hysterectomies, whatever. And now you perform really well on that. You get a 3% bonus on that. Now that commercial payment with a 3% bonus, and how much dollars that's worth, and how over the course of a year that can incorporate into thousands of dollars of revenue for your practice. Kind of the incentive that would be there, that carrot at the end of the stick. Yeah.
So you're probably wondering where the 33% term comes from. Okay, so if you take our commercial payer rate at $85 per anesthesia unit and Medicare at $20, you can see that's not 33%. That's not 33%, but it was whenever we first noticed that it was a 33% problem in the difference in our payment. It just kind of became our tagline, 33% problem. Okay. But you can see that the math is...
it's fuzzy math.
We rebranded it as less than 30%. We didn't want to start using new numbers with Congress. They can barely keep track of all, right? So we're just going to use the less than in front of it. They can follow that concept.
Yeah, I think everybody kind of gets that.
Right.
Well, I think that it's really interesting conversation. I'm glad we could kind of break that down. I want to move in the direction, I think both of you have mentioned QPP, the Quality Payment Program, MIPS, value-based. Mike is from the UK. They have a national healthcare system and work kind of in this zone a little bit more. Wouldn't you say, Mike, whenever you're talking about bundled care or payment model?
We have a system that's probably hard to explain in the scope of one interview, but we're moving towards an integrated care system type approach. So a packet of funding going to a population in a particular geographical region. But at the moment, it's still very much institutions are paid for what they do, and so there's still something of an activity incentive in that, which I guess is. I mean, I'd be interested to hear your definition of value-based care to see if what we're doing is same sort of ballpark.
Sounds like you have it based off of the fee-for-service model, where like you perform a service, you get a fee for it.
Yes.
And then the value-based one is you perform a service, but you also show that you did with some quality attached to it, or reduction in cost or something like that. And then we now get paid a little bit more for demonstrating that as well. Provide the same service with higher quality, lower cost.
Yeah, if we do it better, the patients leave hospital faster, we can do more. Mm-hmm. Therefore, that is our incentive at a hospital level.
Okay. So similar to what we have somewhat. So we've been on a fee for service based system, correct? So what you do is what you get paid for. So there have been introductions of different payment models over the years. So can we break that down just a little bit and start kind of at the basic level of where some of this started and where we kind of currently are, I guess, is a good place to start.
Oh, wow. The history is long, right?
Okay.
I'm talking about going way back to Clinton.
Yeah, you could. I think what a little bit more current would probably be with the Affordable Care Act that was passed in 2015. Right. It had been based, our payment was mostly based on fee for service. The more you did, the more you got paid. And then they wanted to try and make it more of a value proposition where you still do the same stuff you were doing, but now you demonstrate higher quality, lower cost, have higher value. Is that whole healthcare equation. So with the Affordable Care Act, passed in 2015, but started being implemented in 2017, they were really starting to try and transition over into value-based care. You can call it at the individual, the episode, or the population level. So for individual, a lot of it was based off of the merit-based incentive payment system. You, as individuals, myself, Lois, whoever else, would be submitting your quality measures, your cost measures, interoperability, things like that. And at the end of the year, you'd get a score on how well you did, and then a bonus payment. And it would impact your claims 2 years later, because they'd need like a year to adjudicate, and then you can start doing that. For the episode, those are the bundles. And so if your hospital, if your practice with a surgical practice was participating in the bundle, then you'd have target prices for the entire episode of care, where there's the pre-op care, the actual in-house care that happens inside the hospital, and then there's post-op care too, and avoidable care, things like readmissions, unplanned ED visits, potentially sending to discharge dispositions like skilled nursing facilities or rehabs that are in theory avoidable with better care in-house. And there's a population one, which is similar to what it sounds like you might be trying to transition to there, where you can give an entire amount of payment for all care for a population in a certain area or a certain health system, and you're supposed to try and achieve that care for less than the initial target price. So if you might have, say 20,000 patients attributed to that health system, the cost of care should be, let's say, $100 million. You want to try and bring it in at $90 million instead, and you get to share in that $10 million savings.
So using your terminology, we're currently on a journey from bundled to population. So capitation type, but it's a stuttering journey.
Well, it's kind of been difficult with us too. Since MACRA was introduced and instituted, the law passed in 2015, and 2017 is whenever we really started collecting quality data. As anesthesiologists, though, we may not be an eligible clinician or may be an eligible clinician, but our line is pretty much, we're interested in quality care of our patients. So we really want to participate in a merit-based incentive payment program, or if we're part of a big accountable care organization or a healthcare system that can allow us to participate in advanced payment models where we can do more population-based or more broader initiatives that would benefit our patients. We're totally for it. But there is some nuances. Yeah. We have different types of practices in the U.S., some smaller groups, individual groups of anesthesiologists, and it costs money to run a quality payment program. If you wanted to participate in a merit-based incentive program, you would have to put your quality data into a qualified clinical data registry that CMS is certified to be able to do that. Now, our AQI, Anesthesia Quality Institute, runs one of the quality payment clinical data registries called NACOR, and it's one of the biggest ones that CMS has now verified. There's also billers who will run qualified clinical data registries and allow them to integrate with CMS as well. But not every biller does that, and not every anesthesiologist and group or individual has the ability to participate in a quality payment program. It does cost money to do that. So it's a value equation, once again, for the practice, because it could significantly impact how much they make. So since it was instituted in 2017, the highest payment adjustment was 1.85%. 1.85%. Yeah, of $20.
Yeah.
Yeah. So, I mean, you're talking, like cents, right?
Yeah.
So if you do it, you did the math once, Jonathan.
Do the math once.
How many Medicare payment? How many Medicare patients cases did you have to do to actually even make enough money to run your own quality payment program, or pay for a qualified data registry to submit your?
I don't remember the exact number. I did it quite a few years ago, but it was based off of, it was a beautiful napkin. But it was based off the cost that there was a paper in JAMA, the Journal of American Medical Association. It was, one of the authors was a MedPAC commissioner, the Medicare Payment Advisory Commission. They're the ones who basically advise Congress on changes they should make to Medicare. Whether the Congress actually listens to them or not is a different, a whole other top med talk.
Or two.
But they had basically said that they had surveyed providers in all different specialties across the country, and the average cost of submitting MIPS measures was about $13,000 per provider. Now, to get $13,000
per person,
off of 1.85% was, give me a napkin and I'll figure it out for you. But it was essentially working all day, every day, more than 365 days in a year to try and make up that. It's physically impossible to make that back.
Yeah.
So I think where anesthesiologists really have the biggest impact is working within an accountable care organization or a big healthcare system, or their healthcare system that they are working in. Though a lot of groups do participate in a merit-based incentive program, I just don't know if they're getting a positive adjustment based on that amount of money.
Well, and like I said, there's pressure to do that because we do want to do quality work, and you want to contribute to all of the data, all the information going in there to say you've done high quality anesthesia care, but it's hard to make the numbers work sometimes.
Right. And it's how our anesthesiologists are, independent practice, small independent practice, individuals versus larger groups.
Yep.
I don't know how it's structured for in the UK.
Within the National Health Service, the anesthesiologists work for the hospital. So it's always a large.
So it's so much easier, right? Yeah. Instead of being an individual practitioner or solo practitioner. Now, the quality payment program is moving more onto the population health kind of platform itself. It's called a MIPS value pathway. And we were very lucky with the leadership and the staff of the ASA to actually be one of the 12 MIPS value pathways. We have an anesthesia MIPS value pathway. This year is the first year that a practitioner can participate in the MIPS value pathway and report through that. I don't know what the payment adjustment is going to be. I don't know if it's going to make much more. But it's a lot easier to do. And we need to participate. You need to submit 4 quality measures and your results from those quality measures, and one improvement activity if it's a high impact one. So some of those quality measures, and I have them here because I didn't want to mess them all up. This year, they're going to be adding a couple more. But for example, abstinence and smoking, that those sorts of quality measures. Is that what you have as well in the UK? What are some of your quality measures?
It doesn't work like that, basically. We do a lot of auditing of practice, but the payment system rarely is occasionally attached to that. So if I give you an example for emergency laparotomy, major abdominal surgery, we had for a period of time, if you documented risk, you would get an uplift. Oh. So they're very focused. So we've had the same around thromboembolic prophylaxis. And different things, but they tend to be for a period of time, and then it's assumed that you're
100%.
which is clearly not true. So we have additional incentive payments, but mainly it's a tariff per procedure, which means there is somewhat of an incentive to do more, but there's also an incentive to be very smart about choosing which procedures you do.
I see. So the healthcare system makes the decision on
where the practitioners working with the patients, to multidisciplinary team.
Okay.
But talking with colleagues in the US, I think happens less. So we will make positive decisions not to operate, and the financial incentives support that.
Oh, that's very powerful.
Which is really powerful, yeah. So, I mean, in my own hospital, we, amongst the highest risk patients, even on cancer surgery, we've got maybe 15, 20% who are deciding not to have surgery because there are alternatives like chemotherapy, immunotherapy, radiotherapy, palliation. And because the patients for whom that is the right decision are those that are the highest risk and likely to be a high burden on the system, it's a great decision for the patient, and it's a great decision for the system as well.
Mm-hmm. Yeah. So not the way that we operate here.
A little different, yeah.
Within the U.S. The final point that I want to make on this before we move on, we have one or two more things that I want to touch base on is, the future of these value-based care models and how anesthesia fits into that. We don't have a crystal ball necessarily, but if you did have one, where do you think we're going? Because it's all the buzz. I think, for a while, I think value-based models kind of took a back seat, but you keep hearing about them more in this merit-based value pathway and things like that. We're hearing more and more. Where do you think we're moving, and where do you see anesthesiology in the next 5 years on that?
I think we're being forced, not electively moving, but we're being forced into a downside risk model.
Oh, okay.
And it's CMS, their federal payer here, is really targeting primary care providers. They see them as like the gatekeepers to all care that happens afterwards. They make sure you go get your mammography or your colonoscopy, and then from there, other care escalates. And so they're focusing on them, primary care providers, for more of a population-based and downside risk model. So like I was saying before, a certain amount of attributed lives might have a care amount that should cost about $100 million. Well, the downside risk of that is that if you come in above 100 million, you actually need to pay CMS back. Part of it. Upside is only having it where if you come in below, you get to share in the savings. But if you go over, you don't have to pay back. Downside is you have to pay back as well. So it's really kind of disincentivizing extra care that may or may not be necessary, especially some of the avoidable care, like the readmissions, like the unplanned ED visits, like the other excessive things that might happen. And so I think we're being mandatorily pushed in that direction. And as anesthesiology practices, we're kind of just getting pulled in later in the game. We're not part of the target that they're going after. They really are targeting primary care providers in this whole thing. And we just kind of get lumped in afterwards. And part of the biggest reason for that, go ahead.
But except for our bundled payments, like with hips and joint, those.
Totally agree.
Yeah. So we are at the table discussing how we can better care for total hips and joints.
Yeah. Quality is coming back into the conversation. How do we do better care?
Yeah, absolutely. And Jonathan, I mean, you what happened at the the orthopedic hospital with the bundle payment for spine?
What do you mean?
Well, they made a significant amount of money.
Oh, yes. So it's true with more coordinated care, similar to what we have advertised here with the perioperative surgical home.
Yeah, absolutely.
Using that framework, surgeons are trying to do the same thing. Their infographics look just like our infographics. It's a lot of the same stuff, but essentially it's coordinated care. And
yes,
you need
better
leaders,
perioperative
you need an entire
care.
team to do it, right?
Absolutely.
The anesthesiologist should really be at the table driving all those conversations because we touch that patient throughout many parts of those cares. But you can talk about the success of this program.
100%, yeah. So programs that have shown the most success are the ones that really do coordinate that care from the decision that it's made to have surgery all the way through at 30 to 90 days after post-op then too. Trying to avoid some of those things I was talking about before. And also one of the biggest areas that they want to avoiding it is with the skilled nursing facilities after discharge.
Yes, for sure.
So
the disposition.
Probably the best example, most target prices for like a total joint is say like $25,000 or $30,000 for the entire episode of care. Well, a day in a skilled nursing facility gets reimbursed by Medicare at $650 a day. And you can stay in a nursing facility up to a month. So imagine, 30 times 650 and all of a sudden you've hit your target price, right?
Yeah.
And so avoiding those sorts of things that can really make you an excessive, costly center or, episode are some of the biggest strategies going into the surgery. Let's avoid this. Let's try certain things. Let's make sure this patient does physical therapy day of surgery.
Yeah.
Those patients that do physical therapy day of surgery are much more likely to be discharged to home with maybe some extra services or something like that, as opposed to those that don't get their physical therapy until, say, day 2 or 3 after the surgery. Those are much more likely to be discharged to a skilled nursing facility because they need more care in order to take care of themselves, et cetera.
Yeah.
And so,
and detecting frailty and prehabbing patients, nutrition. That is, I really do believe that's kind of the future that we're kind of looking at, is how can we change that episode of care to decrease the cost to the whole environment, the healthcare environment, as well as the cost to the patient personally and their family that needs to take care of that, of the patient. So
we've had lots of conversation about that and all around perioperative care and better perioperative care here on Top Med Talk. It's the main, probably our main thing. Go ahead, Mike.
I think it's an ASA initiative, the Center for Anesthesia and Perioperative Economics. Can you tell us a little bit about that before we close?
Yeah, this is a new center that we have formed, the Center for Anesthesia and Perioperative Economics. The center was... we only have a couple of centers, but this one is really to try to focus our attention on perioperative economics and the struggles that we're facing, how we can all get on the same page and have a unified voice to come up with solutions on dealing with the economic issues that we face. And it's just not Medicare. It's other payers. The No Surprises Act has had...
We didn't get to touch on that very much, but that's impacted it.
Has probably one of the biggest impacts on where insurers are gaming the system and pushing anesthesiologists out of network, out of their commercial payer network, to pay them a lower payment for their cost of care. That probably has one of the biggest effects as well. Welcome to the U.S.
But so this center, I mean, we nicknamed it CAPE, right? That's the acronym, CAPE, CAPE. It really, as Lois was saying, is supposed to elevate the significance of many of the different payment issues. And to be honest, many of the issues were actually going a little bit beyond the scope of the Committee on Economics, and also they required a lot more resources than we have on the committee too. We do a lot of impressive, powerful work, timely topics, other resources, and we have other obligations too when it comes to getting different resources out to even be able to submit anesthesia claims every year. CAPE is supposed to try and take a lot of these issues and also bring some more resources to it. There's a lot of brilliant minds in all these other committees within ASA, and now CAPE's supposed to help coordinate all those and really kind of bring some of these issues even further along.
Lois, Jonathan, thank you so much for sitting down with us. It's been a great conversation. Anything in closing that you want, resources or anything else that you wanted to talk about today that you think would impact our listeners?
We just would really welcome any feedback from you. Connect with us if you have any issues that we can help you with. ASA is your resource, and we're here to help you. If we don't know about the issues that you are dealing with out there, especially economic pressures, then we can't help you as much. And the more we know, the better we can be.
Yeah, reach out to Jonathan to do some back of the napkin math or his presentation.
They're going to
Grand
buy him a new calculator.
Good. I know they can afford that.
I remind people too, when it comes, we talked a lot about Medicare today, and not as much about the commercial side, but the No Surprises Act stuff. There's a ton of resources related to that as well on the ASA website, just like there are for Medicaid and now Medicaid as well. The No Surprises Act and issues that practices are having. And they're telling us, we didn't even need to ask. They were telling us already, but I'm sure there's more that are coming up as more of these lawsuits get, filed, rebuttals from the government on them and et cetera. So final rules and interim final rules, et cetera. So those are some other things.
Yeah. And lots of communication coming out about that and how it affects. So keep an eye out for all of those. Yeah. Been a very great conversation. Thank you so much.
Thank you, Desiree.
Thank you for listening to Top Med Talk. You can find us at topmedtalk.com. All these wonderful conversations are there. They're on YouTube. Going to go out throughout the rest of the conference. We have our schedule up at topmedtalk.com to hear more fabulous conversations just like this one. So please stick with us. Again, thank you to the ASA. Thank you to all of our sponsors that keep this going. And thank you for listening today. Cheers, everybody.